All right, welcome everyone. On behalf of Professor Sherry Grace and Dr. Karam Toykadawi, ICRR co-chairs, and Dr. Gabriela Gysi, the incoming ICCPR chair and user subcommittee chair, welcome to the third installment of our quality improvement webinars. So today's topic is going to be cardiac rehab information needs and patient education. So we have three amazing speakers who are going to talk about patient education and patient education strategies, who will be helping you in your cardiac rehab information needs aspect of your programs. So my name is Dion Candelaria. I'm a postdoctoral research fellow here at the University of Sydney, and I am the ICRR quality improvement lead. So if you have any questions or any topics you want to discuss, quality improvement in cardiac rehab related areas, you can contact me in that email address, or you can use the ICCPR email address. So welcome everybody, and greetings to our participating sites. So as you can see, the International Cardiac Rehab Registry have participating sites from all over the world. Every continent is represented. And certainly here in Australia, we're gearing up for ICCPR provider certification, which is then the ultimate plan is for ICCPR program certification. So we're taking on the first step. So just a bit of an introduction to the International Cardiac Rehab Registry. You have the link there for our initiatives, and as I've said, this is the third topic that we've discussed that we're presenting. The first topic was engaging women in cardiac rehab in early 2023. The last one was barriers and adherence in late 2023, and this current topic is cardiac rehab information needs and patient education. So we'd like to hear from you about your ideas for future topics. It could be mental health or anything that the data tells us. Please do let us know so that we can organize the upcoming webinars. So outline of today's session. So I'll be talking very briefly about patient education, which I know many of you would know, but just to kind of emphasize the importance of patient education in cardiac rehab, we'll talk about the performance of cardiac rehab sites, and then I'll pass it on to Dr. Gabriela Gysi. She'll be talking about patient education in cardiac rehab, and then we would have two speakers from India and Australia, Anjali Zende and Robert Zekin, and they will be sharing their best practices in their programs about patient education. And then towards the end, we'll have a Q&A where we can engage and answer some of your questions that are related to patient education, and more importantly, the innovations and what, I'll be interested to hear what sites are doing before we then wrap up. All right, so that's just a bit of outline. So patient education in cardiac rehab it has many functions, but really it comes down to three main points. So after cardiac event, it's crucial for patients to understand their own condition and to manage that effectively. So patient education equips them with the tools to do that, and to make informed decisions about their lifestyle choices. So really, it's about empowerment and building confidence for them to make the informed choices and decisions about diet, exercise, medications, and risk factors. So this sense of empowerment fosters self-management, and that's what we want. We want patients to take ownership of their own health, and we want them to adhere to healthy lifestyle, which is critical for long-term success, not just during the episodes in their cardiac rehab program. And also patient education is strongly linked to improved outcomes. Patients who are well informed are more likely to stick to their cardiac rehab program first and foremost, but also patients who are well informed can make the choices to reduce their risk of future cardiac events, which then improves their overall health and enhance their quality of life. So that's how important patient education is, especially in a cardiac rehab program. If you have a look at the core components on your right-hand side, a lot of the core components can be at least partially addressed by patient education. You have nutrition counseling, weight management, blood pressure control, lipid management, diabetes, tobacco cessation, and physical activity counseling and psychosocial management. So the next slide, I'll show you the performance of cardiac rehab programs. Obviously, it will be de-identified, and it's a lot to take in, but I will guide you. So on the left-hand side are the knowledge areas, the knowledge aspects that we ask our patients. And we have left 2 sites that are well performing. So congratulations to Mexico and India. They're doing really well in terms of their patient education and patient knowledge section. We have 99.2% and 76.2%. Now, the other thing that I'd like to point out is the rows in blue, which refer to the points of I know my cholesterol level and know how to control it, and I know what to do if I have chest pain, which is concerning. As you can see, overall, they were the least the lowest scoring of all of the least addressed in all of the aspects of patient education. So cholesterol level, I think, in terms of magnitude, I think patients knowing what to do if they have chest pain is very, very important. So I'm showing you this just for you to kind of emphasize the importance of chest pain management, chest pain pathway when the patients are at home, what to do when they have chest pain, and also to make sure they pay attention to their cholesterol in reducing their risk. So again, congratulations to India and Mexico sites. And in terms of the areas that we need to pay close attention to, chest pain management and cholesterol. Yep, so it's like kudos to our highest performers. Again, Mexico and Sir HN in India. So that's it for me. Now I'd like to introduce our first speaker for the night, or for the day for you, for evening for me, for afternoon for the others. We have Dr. Gabriela Gysi. So Dr. Gabriela Gysi, as I've said, is the incoming chair of ICCPR. We are very lucky to have her today. Dr. Gysi is an affiliate scientist at the Kite Research Institute in Toronto Rehab in Canada. Her research focuses on patient education in chronic disease management and global access to cardiac rehab. So this is really her area. We should ask her a lot of questions later on. In collaboration with cardiac rehab programs around the world, she has led the successful development, implementation, and evaluation of an evidence-based patient education curriculum in 10 countries. She's also a member of the executive committee of ICCPR and chair of the ICRR user group. So I'm going to stop sharing, and Gabriela, welcome. Thank you.
Thank you so much, Dion, for the presentation, and hello, everyone. I hope you had a good day, is having a good afternoon, or starting the day fresh like me. So for the next 20 minutes, I'm gonna be discussing a little bit more practical. I'm gonna hopefully provide you with some tools to practically deliver patient education to your cardiac rehab patients. This is the outline of my presentation today. I cannot talk about patient education without touching a little bit on the principles of adult learning. It's key for the success of delivering patient education. Then I'm gonna share a little bit about the assessments that you can do prior to educating your patients. So you can understand about content and modes and really deliver that education based on your patients' information needs, as you can see here, or your patient's some characteristics such as health and technology literacy. And then I'm going to finish my presentation today with some educational resources to support filling those gaps that you have identified or you will identify. So let's start with principles of adult learning. So sorry about the busy slide. I just wanted to put some thoughts here. So adults, they learn different than kids in a way that you have to engage adults in the learning process. So adults see learning as a means to an end. Adults want learning, learning that it's based in real life situations. So you cannot simply just create educational resources or share educational resources with your patients without engaging them in that process. They really want to be actively participating in that learning. And also, they want to only like listen from you, but they want to share their experience. So they want that information to be useful. So you have to think like that's why assessing their information needs is so important, because that will really guide you on what you're going to be teaching them. So, and also adults, they don't want to like that didactic way of teaching, like in a school where there is someone standing and the others listening. That really it's not that effective for adults, and in the cardiac rehab setting as well. So it's great to have like patients in a round circle, let's say, and then everyone has a chance to share their experiences, and they see themselves as equal in that learning process, and that really helps with the success of your patient education initiatives. I really like the last point here. Adults need to know why they should learn, what they will learn, and how the learning will take place. And by this last point, what I mean is that the why is that you have to tell them why this information is important to them. The what, it's really providing maybe in the beginning of the cardiac rehab program, a list of the topics, and so they know what it's coming, and then how they're going to be learning. So really sharing and engaging them in the process, and also really aligning the way that you're learning with how they prefer to learn. So this is just a quick a summary of how I see that this could be successful. But if you have more questions, I'm happy to answer those questions later today, or you can always email me. So let's talk a little bit about assessments prior to educating in cardiac rehab to inform content and mode. So I'm sharing with you 3 assessments. We know there is different ways to assess, and there is different characteristics that are important for you to know that your patient has in order for you to effectively educate. But I decided, because of course I don't want to be talking for the entire hour, I decided to focus on health literacy, technology literacy, and then information needs. So the first thing is health literacy. This is like it says new definition, but this is the 2020 definition. But I really like it because I still 4 years later say that this is the new definition, because if you go to some publications old publications or publications prior to 2020, they really put the focus or the definition or the responsibility of health literacy on individuals. So before, the definition was the degree that individuals have to obtain, the capacity that they have to obtain, communicate, process, and understand basic health information to make decisions related to their health. So this was the older definition, but now, thank God, this is a shared responsibility. So the responsibility, it's not only on the person, but also on the organization. So of course, there is the personal health literacy here, which is continues to be the ability of your patient to understand the information provided and use that information to make health related decisions. But also, the organization has this responsibility to enable their individuals to find, understand, and use that information and make those informed healthcare decisions. And how you're going to do that, it's a key. So again, going back to the first slide, and I'm going to be referring to that first slide often, involving your patients in the learning process, making sure they are engaged. And that's key. That's really key. And that's a way that you can do to support your patients. So quickly, how you can address health literacy in a quick way. People-centered care. So again, coming back to my first slide, making sure the patient is involved in the learning process, engage in dialogue, listen more, speak less, ask what questions the patient might have, understanding and address the patient's concern really based on their experiences, and ideally communicating patients' preferred language. I'm based in Toronto. We are a multicultural country, and the program that I work, we see people with different languages, and sometimes we know there is a family member that comes and kind of translates. We do have translation on site, but sometimes it's not in that language. So it's very important that you communicate, because there is all this cultural background behind it. And the resources that I'm going to share in the end, they are available. They are not only translated, but culturally adapting 10 languages. So I hope it addresses your language and the languages that your patients speak. The second point is use plain language. And plain language, it's a way that it's easy for your patients to understand. You avoid jargons, you explain medical terms, you use active voice, you are concrete on the way that you're teaching them, you keep it short and simple, and that's key for health literacy. So you focus on key messages. Of course, you think your patients need to know a lot of things, and sometimes they do want to know a lot of things, but they're not going to learn everything in one session. Maybe they're not going to learn everything into your 12-week program. You have to limit teaching in a weekly basis, let's say, or the way when you encounter your patients to 1 to 3 key messages, then you provide resources for them to learn at their own. And then when they come back, let's say next week, you can repeat and build on the information, and you can answer some of the questions. The point 4 here, it's the use teach back, which is a technique that you check for understanding in a caring way. You ask patients after you explain to them, you ask them to explain their own words, what they need to know and do. And it's not a test of your patient's knowledge, but it really allows you to check if they understood what you said. This is an easy way for you to make sure they understood your what you just communicated to them. And use higher quality resources. Again, going back to, I think was point 3, the fact that you don't share everything very quickly in the short period of time that you have with them. But if you have high quality resources, you can guide them to those resources, and then they could come back with questions. So how you're going to assess health literacy measurement? There is actually 2 ways of doing. You can assume that everyone has low health literacy, and then you go from that. But if you want to get specifics about health literacy, you can use different tools. There's many health literacy tools available, and I want to share with you this website that I think it's very good. It's the Health Literacy Shed tools, something like that. So basically they have 280 health literacy tools in total, and then they have a search part in the website where you can search, you can find a tool, let's say by, I put like some of the filters that I use by health literacy domain, by administration time. You can do like less than a minute. I'm okay with 10 minutes. I want 20 minutes and so on. You can do the language of the validated version, and then modes of administration. If you want it online, if you want paper, pencil administration. And I'm just providing a suggestion here. We are all in a rush with our patients, so we have so many things to assess and talk to them. So if you want a quick one, there is the brief questionnaire, which is just for items patients take up to 2 minutes to complete. It's only available in English in this website, but there's other validated versions. Like it's not in the website, but you can find questionnaires. You can email me if you want to. I have some versions. So yeah, so this is a great way for you to find this questionnaire to use in your clinical practice. So let's quickly talk about technology literacy. So nowadays, patient education has been delivered online a lot. And how we can make sure that our patients are connected virtually with us. So first thing is that doing this assessment, ask your patients about technology, their past experiences with technology, assess if they have access to a device and internet, and then their willingness to learn virtually. Again, you have to involve patients in the patient education process, independently or on where you're teaching them. So you have to ask them if they're okay to be learning online. Then after that, you have to provide some guidance. So what format are you using? Regarding privacy and consent, this is very important because lots of patients, we learn from past research, they're very worried about privacy. They don't want to share and things online. So it's very important that you address that. Amount of time required, how the schedule will be. Remember, adult learnings, they wanted to know how they're going to be learning, establish rules, and a plan for supervision and set up expectations. So those things are very important. And actually, they're important in any way, any mode of patient education. But in the virtual environment, we learn it's very important in previous research again. And then the third point is how you're going to incorporate key strategies to engage your patients. Please communicate prior to the first session with patients if possible, with emails, building trust. And then you also have to identify your learning needs. Make sure
Na coffee na water. I'll leave siguro mga 7:30.
making sure you know about the virtual platform, the speaker, the camera, and so on. And then you can integrate many patient education strategies. Again, communicating clearly and simply, allow time for question. You can use teach back and so on. The third assessment that I want to share today, or the third, it's the information needs. As I mentioned, again, in the first slide is that the education has to be aligned to the patient's needs and what they want to know and how they want to learn. So we do have in the ICCPR website, and I put a QR code here, so you can scan, but you can go to the ICCPR website under patient education resources. We have this tool called INCR, which has 36 items, and it's available in 3 languages so far. So basically we have items related to all those 9 areas that I'm sharing in this slide, and we ask patients to rate how important those items are to them, how important that information is to them. And then they can also tell us if they think or if they know enough about that. So let's say some patients really know about nutrition. We are asking them questions about if they know about let's say the quantity of salt in their food, if they want to know more, if they think that information is important to them, and they can rate between 1 and 5, not important at all to very important, and then they can also inform if they know enough about that. So the great thing is that the INCR areas, they match the registry knowledge questions that Dion shared with you earlier. So I just put it here quickly. I'm not going to go through that, but all the questions, all the knowledge questions really are part of the INCR. So you can identify the knowledge earlier in your program and really work with patients in their patient education journey, so that hopefully in the end they feel more empowered, that they know that those topics. So I just want to share some research here today. My purpose with this presentation was not to be research heavy, but I could not share this. ICCPR recently has done a global assessment of information needs. So we assess cardiac patients, 1,600 in and outpatients around the world. And actually, we just received the confirmation that it was accepted yesterday. So good time for this. Yeah, thank you. Good time for this presentation. So basically, we have different, we of course, we assess the information needs in different groups, in different categories. So I'm just sharing some of those results. This is for income class. So we have the highest information needs by income class. So we have 17 countries, if I'm not wrong, that we assessed. And then just so you can know a little bit about the information need of patients globally. So for those living in high-income countries, symptom response and medication were the highest needs. And symptom response really aligned with what Dion just shared about what do I do if I have a chest pain, right? That's one of the highest information needs that I've identified in any information needs studies that I've done, and I've done a lot in the past years. In the upper middle income countries, again, symptom response and medication, and there is a symbol there I'm just going to explain to you. And then the lower middle income countries, cardiovascular risk factors is the highest need. And what I mean by those asterisks in both upper middle and lower middle is that, again, we ask them whether or not they perceive they already know enough about each one of the topics, and we call this knowledge sufficiency. And then for symptom response and medication in the upper middle countries and lower middle cardiovascular risk factors, we identify that less than 50% of our respondents in those countries identify they don't even know about those topics. So that's a red flag for us that we really need to address this. And just quickly, because I don't want to take a lot of time and I want to take more time to share the resources with you, this is by region. So the top information need by region. So in Africa, do I need resistance training? How do alcohol and drugs affect my heart? How do I exercise safely? In the Americas, what should I do if I feel angina and chest pain? Again, really matching what we identify in the ICRR results. When should I see the doctor or go to the emergency room? Again, what should I do if I have a chest pain? All this about symptoms and how exercise helps my condition. In Europe, what medications do I need to my heart? What happens when someone has a heart attack and other heart event? What should I do if I feel angina and chest pain? Again, Southeast Asia. What medications do I need for my heart? How do I take my medications in the right way? What should I do if I see what should I see a doctor or when should I see a doctor and go to the emergency room? In Western Pacific, what happens when someone has a heart attack? What should I do if I feel angina, chest pain? When should I see the doctor or go to the emergency room. So you can see lots of similarities, information about exercise, medications, the emergency, the symptom, the chest pain. But again, it's great if you could identify your patient's need and work with them throughout the program. And the INCR tool, it's a great way. And also, when your patients complete online, the system or the website will identify for them their top information needs. So they will have that. There is a way that they can print that information and they can bring that to you. So there is a great way for you to work with your patients in that context. So again, your patients can complete the questionnaire online. The top information needs are identified, and also they are directed to resources to learn more about those top needs. So if they complete it, the system or the website will direct them to the resources in their own languages. Again, we have English, Portuguese, and Simplified Chinese for now. And in the global survey that we've done, we identified that this information, the resources provided were 4.4 in the helpfulness rating. So they were high. Patients identified it was very helpful to them in a scale out of 5. This is just a quick example. So if the patients identify a top information need, what food should I eat for a healthy heart? They will be directed to 2 resources, one related to choose heart healthy foods, and another one, what is healthy eating? They're both evidence-based resources. And then if you can scan here, you can find a document where all the resources are listed. All the resources that patients will identify when they completed the questionnaires are listed here. So let's quickly talk about, Dion, how many minutes do I have?
You have 4 more minutes.
4 more minutes, perfect. Okay, so just quickly talk about some strategies, and actually it's just one slide. Again, it has to be patient-centered. It would be great if you can involve family and caregivers. In some cultures, the wives are the one responsible to cooking, or they maybe don't understand what their family members are going through. So it's great to involve family and caregivers so they can learn about that too. And sometimes family and caregivers, they do have risk factors too. So it's great to learn. It's kind of a primary prevention, understanding the needs and preferences. As I mentioned, consider your patient's prior knowledge could be something you can involve, knowledge assessments, ensure the level of difficulty giving health literacy, applicable to patient's context. Again, learning about your patient so then the education can be applicable to them. Consider patients' health and technology literacy. I provided a little bit about it today. And then leverage technology. There's so many resources. You don't have enough time to educate your patients, so you can guide them to the right resources, and that's key in this process. So as I promised, here are some resources that I've worked and that I've been working the past years. So this is Health University. So this is an open access. It's free, it's evidence-based, it's patient-informed, it's comprehensive, it's virtual. So we do have a website called cardiaccollege.ca with resources for cardiac patients, but we do also have resources for diabetes as well in the diabetescollege.ca. So all the education is divided into 5 areas, and each area is color-coded. So all the resources for treat disease, which includes medication, includes what to do if I have the symptoms, it's all in blue. What is heart disease, about procedures. Then you have the Get Active, which are resources about why exercise is important to me, resistance training, how I can do resistance training at home, how I can exercise safely, and so on. Eat healthy, what is heart healthy eating, how I can eat healthy, some tips and so on. Feel Well, which is the psychosocial part, and then Take Control, which provides resources for self-management. And then I just forgot to mention that risk factors are under treat disease. Because treat disease, it can be treat diabetes or treat heart disease. That's why I just put treat his disease. And then just one of my final slides, those resources are available in 10 languages. And there's multiple resources because, again, people learn differently. So it's great to provide resources like maybe a booklet. Some people prefer reading, others prefer long videos, others prefer just a short key messages. So we have different resources that educate the same content. So we have like education sessions, which is like a video like with the outline, 45-minute, 1-hour videos. We have women's cardiac rehab classes in French and English. We have also short videos like, why do I need cardiac rehab for the rest of my life? What is PCI and resistance training? So we have those short videos. We have the content on the website, the text that they can read, they can go around with pictures. We have program manuals for patients and healthcare providers to deliver cardiac rehab remotely, which is under My VCR tab. We have the guidebooks. We have 9 guidebooks that patients can download, they can print. And we have this 12-week educational program called Thrive, where each week patients watch a short video and they can create their weekly goals. And they, in the end of the week, they can reflect what went well with that goal, how they can do differently. So it's a great way. Each week, it's based on one of the key areas, one of the 5 key areas. So let's say week 2, it's about sleep well. Week 3, it's about how do I start exercising? How do I start doing resistance training and so on? So it's great resources. And the latest, last year, we identified that we needed to have resources really focus on women. So we created Cardiac College for Women. For now, they are available in English and French. They cover all the 5 education areas. They are open access. They are evidence-based. We have done some research. And we do have 12 sets of slides available to support your program. So if you want to do education that it's focused on women, I'm happy to share those slides with you, and you can change to your own language. You can adapt to your patient's needs. So we share those resources with programs. And here are just a illustration of the resources that we created. You can scan that code over there so you can see all the resources, all the links. But if you go to cardiaccollege.ca, you can also find those resources. And that's it for me. Thank you so much. I'm happy to answer your questions in the end of today's session. Thank you.
Wow. Thanks very much, Gabriela. That is very comprehensive, but packed at the same time. I really like that you started with the establishment of the principles of adult learning, because I think that's very important. But at the same time, you built on and talked about health literacy and technology, like e-health literacy, which is very important. And then, of course, all of the resources you've shown. I'm sure a lot of our participants today would be looking for those resources. So thank you. I know Gabriela needs to go shortly, so if you have any questions, perhaps put them in the chat, and maybe later on during the Q&A session, we can go back. All right. Thanks very much again, Gabriela.
Yeah, I'm going to put in the chat my email. So if you have any questions, if you want to share an email, I'm here to support you too. Okay.
Thank you. Thanks, Gabriela.
Thank you.
All right. So do I share my screen? And our next, so we now proceed to our next speakers. Our next speakers are going to be talking about the strategies that they employ in their own services, in their own cardiac rehab programs, regarding patient education. So our next presenter is Dr. Anjali Zendi. So Dr. Anjali Zendi is a consultant physiotherapist with 18 years of, with 18 years of experience, specializing in cardiac, pulmonary oncology, and transplant rehabilitation. She played a pivotal role in setting up and launching the cardiac rehab department, ensuring adherence to quality control standards, and implementing effective marketing strategies as well. She is certified in race emergency medicine by World Athletics and recognized as a quality management examiner, where she has contributed to the advancement in healthcare quality and safety. Her involvement as a medical consultant for prominent marathon events has promoted health and wellness within the community. She's also an awardee of the ICCPR Foundation CRFC Cardiac Rehab Foundation Certificate Scholarship, supported by Solve CHD, and she has led the team at Sir H.N. Reliance Foundation Hospital with Dr. Ashish, contractor. Okay, thank you very much, and welcome, Anjali.
Thank you so much. So here I'm going to be presenting the best practices at Sir H.N. Reliance Foundation Hospital as with regards to the patient education systems policies that we try and implement here in our organization. So by now, we all are aware of the importance of cardiac rehabilitation in our lives and how it is, helping our patients to be able to not only get back to normalcy, but then to have a better quality of life and from a future aspect of risk reduction and, promoting physical well-being. It is one of the very, very important aspects that has that we are blessed to be able to, apply for our patients or avail those services for our patients. So the common areas that we as identified in our setup of Sir H.N. Reliance Foundation, which also happen to be the core components of cardiac rehabilitation, are when they come to the rehabilitation department, when they see the setup, obviously the first thing comes to everybody's mind is what is the nature of exercises that we need to do? Why is it essential for the exercises that we need to do? Certainly the education and counseling, because we are a holistic approach department or department, then there are certain areas that we cover for each and every patient who walks into our department. And the risk factor management, the control of blood pressures, cholesterol, weight, and certainly the other risk factors. Now, the main point out here is that how do we, as Gabriele said, that I mean, the principles within the principles of adult learning, it is very essential to understand understand from a patient's perspective their idea of what risk factors are, their understanding of risk factors. So based on those is that we have designed and we keep modifying our patient education program to enable, to facilitate, and to make it like really easy for everybody to understand, because India is a vast country. Within the subgroup or within a certain set of patients, there would be like 10 different languages spoken, 10 different levels of education, 10 level difference of understanding. So basis each patient's need and requirement, we don't have an authentic or a stable patient learning program or trying to understand what they are. But based on our experience purely, we tweak the education and counseling programs as per each individual who walks into our department. So this is our team. Like I said, that we maintain a holistic team approach in our organization. We have Dr. Ashish Contractor, who's the head of the department and who's an exercise physiologist himself, specialized into cardiac rehabilitation. And then we have, the others are my team members. Then we have a clinical psychologist, we have a clinical nutritionist, and yoga being a primitive part of the Indian society, we have yoga as well, part of the program that we offer to the patients. And the program runs in a way that understanding the socio-economic condition of the individuals. There's 1 month program, which is 12 sessions. Then subsequently there is 3 monthly, 6 monthly, yearly. And if you break it up into weeks, then it becomes like 12 weeks, 36 weeks, and so on, 52 weeks, etc. Now, every month we'll have 12 sessions of exercises, 1 session with the counselor, 1 session with the nutritionist, and 4 sessions of yoga, which is apart from the days that the person comes to the rehabilitation department for the exercises. There is 1 session, additional 1 day, which is reserved for the yoga sessions. Now, how do we do that? Basis the stage that the person comes to us with, like an immediate post-operative or a person who's been into the system for a long time. We divide them into batches relevant to their condition, to their situation at that time, because then they are able to, like Gabriele said, that I mean, in a group, when they see people alike, when they know that, okay, they share similar emotional, physical needs, etc., it becomes far easier for them to identify and gel within that and kind of continue or adopt to that best practice, whether it is yoga, whether it's exercise, etc. So we have designed the groups in those manner. So this is my team. So before, the patient education program was an integral part of the program out here. But did it? No. Was it kind of charted? Were the results noted? It wasn't there. So once ICRR came into picture, and once we started as in once the first pilot happened, and we understood that, okay, these are the questions that would need to be asked. These are the questions that would need to be conveyed to the patient. That's how we started working around our patient education system. So this is the flow chart, like as you see. The AR staff educate, initially it was just the patients who were referred to us by the primary physicians or the cardiologists or the cardiac surgeons. And when they came to our department, is that when the education of what cardiac rehabilitation is, what risk factors are, what is the nutritional need, etc. All of these things were, as in the patient was taken through that education format. Like the information about their initial, as in on the first visit to the rehab, all the initial assessments were done, which were relevant to the needs of the organization and which fell in line with the needs of the quality assessment tools that the organization was using. All of these things were done. The initial assessment, the demographic details, patient outcomes on the initial, and by the end of the program, all of these things were noted down in a very, very detailed manner, and patient report was generated. Like ICRR has a lay summary that we can generate once the patient is through the program. Similarly, on our own level, even when ICRR wasn't into picture, we still continue it, and it is one of our best practices, which has been appreciated by the medical fraternity around, is the progress report that we generate for the patient. Now, the progress report is quite a holistic report, wherein we not only note down the details, the current health status of the individual, but then what are the risk factors that the individual should be addressing to on a long term as well, plus what exercise prescription do they need, what is the ideal exercise prescription. Like we have this FITT principle as per the ACSM guidelines. So we put it down onto that note for the patient to be able to carry it home even when they are not with us as an organization. And we are always open to having them back. Any problems, any questions, the lines, as in the communication channels, are quite open on that front. So this is what I'm showing you is the process before the intervention of ICRR that we applied. So this is what we did. Then we identified what the 5 W's and 1 H. We applied the principle to the patient education to try and fill up those gaps to enable us to be able to, achieve those benchmarks that were being set internationally, let's say by ICRR. And then so we started like talking to the patients more on an individual level, but the process started far before the patient could land up into the cardiac rehabilitation department. So we tracked the journey of the patient right from this. I'm stating one example of like a surgery patient whom we had access before surgery, not the emergency surgery ones, but the ones we had access before surgery. So right from before surgery, and the patient education then started modifying. We started modifying them as per the need of that hour. So if I met a patient before the surgery, my education is kind of restricted to the next 1 week, 10 days that the person is going to go through. Then what is supposed to be done within once the patient is discharged. Then the progression happened to why an individual needs to come to cardiac rehab. Then based on the needs, based on the assessments on the day one, is then we started modifying, tweaking their exercise program as per the society that they are living in, the kind of support that they had around them, the kind of food patterns that they would be, culturally, it's like a vast society. So that in those manners, we started tweaking little, bringing in small changes to be able to empower the patients to enable their recovery process to being normal, near normal, and then, kind of follow the healthy lifestyle even after surgery. Then we started involving, and the best part is because of the quality initiatives of the department, we started training the patients about like the challenge has been, what do I do if there's a chest pain? The cardiologists, the cardiac surgeons, then they started involving themselves into patient education on that part. The organization on a level of what we say as patient education. So what we have realized is here in an Indian scenario, when people have some literature to read, as yes, the population is now becoming tech savvy, but if they have something to read in a language which is comfortable to them to understand, to read and absorb, we started giving them literature in different formats as to what needs to be done if there's a chest pain, in emergency whom to connect to, and what all things to be done. So this particular literature goes with every patient who comes to the department as an initial information leaflet to the patient. So all of these things, all these initiatives started to fall into place to what they are today. There are challenges, there are barriers, which I'm going to discuss further. So this is our statistics of what has been shared with us. And if I've got to, break them down as to what all things we do with these patients is, I'll just in short speak about them. For the first question, if I was informed about cardiac rehab or do I have a primary healthcare provider, usually cardiac rehabilitation is a referral program in India. So yes, as in they knew about it. And since our education format started right from the patient admission to post-operative, then suture removal, and then coming to rehab department. So yes, they knew about it. As far as the medication part of it is concerned, we specifically, like on one-on-one basis, what the patient needs of the medications are, the risk factor profiling is. We have one-on-one session with regards to the medication care. And as far as the stress is concerned, we have a counselor. Like I said, every patient, when they walk into the department, has got one-on-one session with the counselor. the counselor does generate some literature, which goes to the patient by the end of the session. And when the patient walks out of the hospital, he or she has a proper exercise, as in the progress note from cardiac rehab, the counselor's notes, the nutritionist's notes, and well, as in what all things need to be done, or the simple yoga asanas that can be carried out. Do I know how much exercise intensity that comes into the progress report and one-on-one on a daily basis as the patient is progressing, basis that the counseling about what needs to be done next, so that we can progress is also spoken with all the patients. Like I again said, there's a nutrition counseling that happens for every patient, and now this is customized to each patient, is because every patient, the patient ideally is, before the diet counseling happens, is taken through what we say as the food recall is given to a patient who fills in for 3 to 4 days, and specifically what they normally have on normal days. And then the dietitian kind of sits with them, understands their cultural needs, their basic eating habits, and basis that is that heart healthy diet is a standard recommendation is given. And if they have any doubts, because the whole team is on the floor all of the time, then they can kind of communicate with the dietitian on what suits them, what's not, and any other doubts if they have. Like I said, the education. Now coming to the blood pressure, cholesterol, diabetes, etc. We have been sitting down with patient on the first session, taking them through what we call as the patient education PPT, if I've got to put it into simple words, and a literature is handed over to them in the language that they are comfortable. Some of the literature we are using from the ICRR side, mostly the diabetic control and the smoking cessation programs as well. The rest of the literature we do have in our organization has it in different languages, 4 different languages: English, Hindi, Marathi, and Gujarati.
Anjali, 3 minutes.
Yeah.
Wrap up. Thank you.
So I have taken you all through the journey of the patient likewise. So pre-operatively, post-operatively, and how the education happens, and that's how. And in the now the addition to it, I would want to say is that the annual assessments that we are doing for the patients, whether they are within the system or whether they are off the system, is really enabling us to understand if whatever we have imparted to them, whether they are absorbing that or they are following that or not. So which is working, and let's see how the annual assessment reports come out to be. So this is one of the samples of the patient education literature brochure that we give patient at one particular stage. This is not the holistic, but this is for them to understand what cardiac rehab is. Before they are discharged out of the hospital, each patient has this, whether it's a surgical patient or a plasty or a medical management case. Now, we all of us know the outcomes of what a patient education does to patients, obviously adherence and better outcomes, and which we have realized into the annual assessments that we have been doing. It's quite encouraging. Educational topics, like I have already spoken about it, and we have proper literatures shared with the patients. Now, solutions, achieving the benchmarks is, we are trying to utilize the ICRR tools to improvise our patient education programs, getting a feedback from the patients, from the staff, as to what exactly can be done to make it more patient friendly, to involve technologies into it, etc. That's how I've already spoken about the adherence of the quality measurements that are present with us. So that is really helping us to stay on track of the patient needs in terms of patient education.
Thank you.
Cultural barriers are there. The fraternity, there was lack of awareness of the cardiac rehab, but because it's a multidisciplinary approach and there are constant mechanisms, constant meetings that are happening, a lot of these barriers we are able to, counteract. Individualize. The best part about the Indian scenario is that a patient is never alone. It's family, it's friends, it's the support that is present. So that helps us to communicate what exactly the patient needs to do or understand and carry out further for their own benefit. Continuous monitoring is still a challenge, but that's where we are trying to work. Now, the gray areas we have already spoken about. What we have started as doing as best practices is that we are engaging more with patients at different levels, close monitoring of the adherence of the goals set for the home program, quality reviews. Annually, we are connecting with the patients and is monitored through as in relevant touch points, as in we are trying to speak to them more and more via the multidisciplinary team and engaging them and making them understand the importance of cardiac rehab and the lifestyle modifications. So this is the example of the progress report that we generate for our patients. I'm sorry, it's a little crooked because that's how the scan went to the patient. But this is, you would understand in the brief history, we have given the understanding of the patient's disease, the outcome measures that the patient is being taken through every periodically. Graphical representation always works. And I have not put everything from the progress report, but this is like one gist of the exercise prescription. If you can see what exactly can they do, age-related heart rate, target heart rate, etc. All of those, the current program and what needs to be done is mentioned in here.
Angela, if you can wrap up, please. Sorry.
Yes.
Yes. Thank you.
All right. So I'm on my last slide.
Perfect.
It is immediately post-operative, as in as soon as you tap the patient, the better it is. And we are trying to implement more of educational videos, testimonials to improve awareness. Right. Okay. I'm through.
Perfect. Thank you. Thanks very much. No, again, very comprehensive. I think two main key points. Number one, I'm glad that you are using and really applying the resources and the the knowledge from ICRR. And I think the second point is, I think the power of your service lies on the multidisciplinary team. Like you can see how strong it is with the staffing.
Yes.
It's amazing. So well done. Congratulations.
Thank you.
Alrighty. Now now we're on our last but certainly not the least is Mr. Robert Zekin. Robert Zekin is the nurse manager of the cardiac rehab services in Western Sydney Local Health District here in Australia. He has over 30 years of experience in cardiac rehab and is a clinician researcher. His current research focuses on the nurse-led exercise training, women with heart disease, cardiac rehab quality indicators, which we've worked together on, and data management. His expertise in the field of cardiac rehab is recognized in Australia by being awarded the Australian Cardiovascular Health and Rehabilitation Association's Alan Goble Distinguished Service Award in 2021, and he also gave the prestigious cardiovascular nursing lecture at the Cardiac Society of Australia and New Zealand Conference in 2022. Welcome, Robert.
Thank you. Can you see?
We can see the presentation slide, the presenter slide, sorry.
Oh, okay, sorry.
Yeah, it's the other screen.
Is that better?
That's better. Perfect.
Okay, sorry. Thank you for inviting me to talk about improving patient education to increase knowledge and self-management. A lot of the things have already been said, but I'll continue on with some of the more local issues that we've had here in Sydney, Australia. So this is the World Health Organization definition of cardiac rehab, and in particular this portion of it, the most important part of this is by their own effort. And that's basically saying that, you know, the impetus of the learning is on the patient that is receiving the cardiac rehab. And that by doing this, they can improve their health behaviour. But I'll delve into that a bit later. We all know that cardiac rehab or exercise-based cardiac rehab in this Cochrane systematic review showed that it was better for health-related quality of life and cost effectiveness, and reduces risk of cardiovascular mortality, myocardial infarction, and hospitalisation. And these, as shown before, these are the core components. Education is embedded in most of all these core components, but there's actually not one there for self-management, and there's not one there for education. So maybe they should be separated as well. And the characteristics of cardiac rehab, it should be comprehensive, initiated as early as possible. Here in Australia, it's 15 days post-event, so it's quite early compared to our international benchmarks. Continuous, make it staged, individualised, depend on the clinical state, and acceptable for the patient. Just a little bit about where I'm coming from. This is Western Sydney LHD, which has roughly nearly 1.2 million people living in this area. And I have 4 sites that I manage in this area. And we enroll over 1,000 patients a year with cardiac disease. In our census, 50% of our population were born overseas. And as you can see, the top 20 languages are quite different. And also the countries where they coming from are also multifaceted. And we also have over 13,000 people who identify as Aboriginal or Indigenous to Australia, and they have their own subcultural issues and language components. And we all know, as I stated, that we have a very large ethnic minority, or nearly majority now, in our area. But we know that they continue to remain disadvantaged when accessing healthcare interventions such as cardiac rehab, and that's for many reasons. In an Australian study, it showed that referral to cardiac rehab were lower in the English as a second language group, and patients who actually have English as their second language have poorer outcomes than patients who use English as their first language. We've did a study in our area, and we're looking at the diversity of the patients enrolled in the 4 cardiac rehab programs. Overall in Australia, as you can see, we have a multitude of areas where patients come from, and the majority of those actually come from Asia, the larger Asian continent, which includes South Asia. Overall, nearly 7,000 patients were enrolled in the 4 sites in the 7 years, and of those, 65.5% were born overseas, with the top 5 country of births being India, the Philippines, Lebanon, Fiji, and Sri Lanka. In regards to Fiji, the majority of those patients are Fijian Indians. And the top 5 country of births for each individual site differed from each other, reflecting local population diversity. We have diversity within diversity in our area. So I'll just show you our top 5 countries of birth. So this is site 1. So 36% were born in Australia, with 2.6% of these are Indigenous. The next, numerically, India, Lebanon, Sri Lanka, and China. But this differs a bit to our site 2, where Australia is only born in Australia was only 21%, but no Indigenous. A large 17% are born in Lebanon, followed by Turkey, China, and Vietnam. 13 kilometres away from that, we have another site, and as you can see, Australia is Australian born is 35, with a larger majority of Indigenous patients, followed by the Philippines, India, Fiji, and Sri Lanka. And in the same local government area, this one here has 40% born in Australia, but nearly 11% are Indigenous, followed by the Philippines, Fiji, India, and New Zealand, closely followed after that by Pakistan. And as we know, during COVID, around about 75% of cardiac rehab programs closed, but our area did not. In this research during COVID-19, looking at remote delivered cardiac rehab by Dion, he actually showed that participation by ethnic minorities using remote delivered cardiac rehab was much lower. So we, as I said, we stayed open, and we actually presented this in Barcelona at the European Society of Cardiology last year. And as you can see, during COVID, we actually increased our activity, and that's mainly because the areas around us all closed down, so everyone decided to come in. And there wasn't really much difference in regards to age or male gender. There was a slight differences in regards to who actually came. We actually had an increase of patients with heart failure and a decrease of patients with elective PCI. In our programs, we actually gave the patient choice. So we actually had supervised training, face-to-face, supervised training, face-to-face plus home walking, and telehealth. And as you can see, telehealth was only taken up by 6% of the patients. A lot of them wanted to get out of home, I think, in the lockdown. And as you can see, our wait times were only 21 days for each site. We do know that there are barriers and facilitators to virtual education. And most of it, even in our first world country here in Australia, we have issues with internet and technology as well. You try a Zoom meeting where everyone drops out or can't get on, or there's sometimes issues where you live. But we are trying to address it. We're actually looking at avatar-based discharge education in English and soon in Chinese. But there are many barriers to educational attainment and learning in cardiac rehabilitation, and they could be cross-connected, they could be singular, and in our patients, cognitive impairment or brain fog has been lately shown to be a large component of patients entering cardiac rehab. Some are mild, some are moderate, and some are severe. Patients who have hypoxic brain injury or chronic hypoxia have issues with learning or attaining education. As I mentioned, immigrants, language diversity, low educational status, low health literacy, or just illiteracy in their own language can be an issue. Depression, anxiety, stress, post-traumatic stress disorders, and mental disorders are quite high in our society here in Western Sydney. Aging, which includes things such as dementia and Alzheimer's, Parkinson's disease, also is a barrier. Medications, both drugs, both legal and illegal, can play, or even pain treatment, pain control medication, all can be a barrier. And as you can see, in Sydney or Australia, we've actually done quite a bit of research on cognitive impairment, as well as prevalence and impact of depression, anxiety, and cardiac rehabilitation. In regards to hypoxia, they include all these patient populations that we normally see in cardiac rehab: out of hospital cardiac arrest, patients with heart failure, congenital heart disease like Alzheimer's, Eisenmenger syndrome, comorbidities such as lung disease, COPD, obstructive sleep apnea, pulmonary arterial hypertension, and chronic anemia. And the list goes on. Alcohol abuse, chronic traumatic encephalopathy or CTE, especially in footballers or contact sports. That's coming more to the fore. Patients with nutritional deficiency, such as folic acid and thiamine deficiency. Patients who have sleep deprivation, they work on night duty or they work a couple of jobs. Patients who are vision or hearing impaired have difficulty in attaining or learning issues about their heart. In regards to level or stage of grief, they could still be in the denial stage and therefore, nothing really happened to them. They don't accept the fact that they've actually got heart problems. Patients undergoing cardio-oncology, so they're undergoing chemotherapy and having heart problems at the same time. Patients who've previously had strokes, and women in young women and older women in particular have some issues with learning, and I'll get to that now. And as we know, knowledge does not equal behaviour change. You can impart all the knowledge, have all the resources, but that may not necessarily change behaviour. The patient has to want to change that behaviour and after gaining the knowledge. And patient factors affecting accurate risk perception of their heart disease is again multifaceted. They include age, gender, so female less accurate in regards to the perception of their risk. As we mentioned before, patients from overseas or immigrants have are less accurate. Patients who have lower education are also less accurate in their risk perception, and also misconceived beliefs, or they could be cultural beliefs as well.
4 minutes.
So, yeah.
Sorry.
So we have patients who get a lot of wrong and or mixed messages, and they include things such as Dr. Google on the internet. Patients get to see what the first thing on the internet is, and it may not be correct. And also, or given poor advice from family members, take this herb, or, I'll crush it up for you and it will make you feel better. And as I was talking about in regards to women and their barriers, this is an article about a woman who's worried about the effect of her unborn child from the sound of jackhammers while she's smoking a cigarette. But she doesn't see the cigarette as a problem, but the jackhammers are. And this is a quote of what she said: "Stress killed me for 20 minutes. Excess busy lifestyle was almost a death of her." This is a patient that we knew, and when she actually got interviewed by a magazine, and this actually came from the magazine. And this is what she said, and this is what we know. She had the background depression, is a current smoker, she's obese, has raised homocysteine levels, and has a poor lipid profile. She refused take rehab post-discharge despite many times of encouragement. And from our literature review, we find that the literature suggests that women source most of their information on health matters from magazines, television, newspapers, and in internet, as well as healthcare providers. And this is by Layla, who wrote this and stated that a lot of women contributed their disease to stress. That's 55%. And in particular, Middle Eastern women in this study showed inaccurate causal attribution to coronary artery disease. So the implications for cardiac rehabilitation: we need to identify the needs and the patient's preferences. We need to assess the perception of risk. We need to tailor and develop interventions for these patients. Identify vulnerabilities and risks. Refocus on information sharing rather than education and teaching, and more listening rather than talking. And potential facilitators to increase health literacy in cardiac rehab: explain the pump, make the heart the main reason why they're there, and what the importance of that pump, and know their numbers. We've had patients who stated that because their left ventricular ejection fraction is 50%, that they lost 50% of their heart function. So you need to address that and re-educate. Individualise the education content and level. Reinforce or re-educate at every opportunity, even if you just drip feed them. Involve family members in all aspects of cardiac rehab, and that sometimes including the family members in the exercise component and all the rest of the opportunities that their partner has. Utilise health interpreters. Utilise educational materials in their own language or their culture. Utilise educational boards to facilitate conversations while they're actually in the clinic. Peer support is very important. And sometimes maybe use things such as motivational interviewing, even though the in this paper it stated that was actually increased the intention to attend cardiac rehab, but in our studies it showed no difference between, in a randomized controlled trial, between those who did receive motivational interviewing and those who did not. So in conclusion, there is no magic bullet. Treat all patients entering cardiac rehab as individuals who have different strengths and weaknesses. Find the best way to make a difference for your patients' better heart, body, and mind health. Thank you.
Thanks, Robert. Thank you very much.
And there's a plug.
So come over to Sydney for Accra. So I think the slide that says knowledge does not equal behavior change is really important, because I remember my undergraduate professor was saying, well, if that were true, then no health professional would smoke, because obviously where everyone's knowledgeable. So anyway, thank you very much for all of our speakers. I think we have 4 minutes left. So oh, hang on. Am I sharing the correct screen? Right. Am I showing the correct screen?
Yes.
Yeah, okay, cool. Perfect. Thank you. So concluding thoughts, I think in summary, Gabriela has spoken about a lot of things, but really she went back to the basics of adult learning and then health literacy, then e-health literacy, and provided us with resources. Anjali spoke about their own experience of providing patient education, and as I've said, I think really the strength lies on the multidisciplinarity of their team and the different touch points and the processes that they have in place to address each patient's needs at different points in their care. And then Rob talked about the different approaches and the multidisciplinarity, the multicultural patient population that his programs have, and how to kind of adapt to that and make sure that they have translated versions of resources and make sure that they have evidence base for the things that they do. So I think it's been a really good session. Now we have we only have 2 minutes for Q&A, so I would probably say put your questions in the chat. Unfortunately, we won't have time for this, but it will be interesting to see what the other participants do in terms of strategies that they have in place for their patient education, especially the innovative and the creative ones. But maybe if you can share in the chat and then we can circulate in the group later on, that would be good. Also, Gabriela put in her email in the chat if you have questions specific to her. Given that this is her area of expertise and she's done a lot of studies in this area, please do reach out to her. I have a plug. There's an ICR community, QI community session that we conduct after our webinar. So this session will not be recorded. It's confidential, non-judgmental. But it's really brainstorming and sharing of experiences, sharing of troubles, challenges, and potential solutions. I think, Fabia, if I'm not wrong, it's the 8th of May, Wednesday, 6 a.m. Is it still Eastern Daylight Time? Is it still daylight? I
Yeah,
think,
that's correct. It's 6 a.m. Yeah.
yeah, 6 a.m. EDT. That would be, I suppose, the same 3:30 in India and around 8 o'clock in Australia. And so I encourage everyone to please attend that. It's going to be more, there's no presentations. It's going to be more interactive session with other site providers. And the last slide is, a reminder of, we have video training resources, and they're publicly available. They're on the ICCPR website. This webinar will also be recorded and will be uploaded to the ICCPR website. So maybe give us a couple of weeks and it will have its own kind of tile there. Otherwise, do follow us on X. We have Facebook, Instagram, and LinkedIn. Otherwise, thank you very much again to Robert and Anjali, and of course, Gabriela, who is not here in the chat anymore. But I hope you found this session helpful, and we'll let you know what the next topic is, and we'll see you there. Bye, everyone.
So much.
Bye. Thanks.
But thank you.
Thank you.